Alert Medic 1 respond. Box area 19
You're listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.
Hello and welcome back to the Alert Medic 1 podcast. My name is Mustafa Siddiq. I have Ken with me.
Hello.
Today we're really excited to be talking to a flight nurse, which I think is super cool. That'd be like one of my dream jobs, I think. So Erin Berry, I met Erin at the Johns Hopkins Hospital when I was doing my CNA to EMT clinicals, which that exists. EMT to CNA clinicals. And so Erin graduated from her Associates of Nursing program in 2009. She started her nursing career in the surgical ICU at the Cleveland Clinic. She then moved back to Indiana, where she worked in a trauma ICU at a level 2 trauma center and a neonatal ICU. During this time, she completed her BSN at Purdue University. After moving to Maryland, she began working at the newly opened critical care resuscitation unit at Shock Trauma, which I've been there. It's pretty cool. She wanted to, after that, pursue her interest in critical care transport. So she moved over to the Johns Hopkins Lifeline critical care transport team, and in February of 2018, she made the transition to flight nursing. Erin holds certifications as a CCRN. Oh, you'll have to help me with these. What do these different things mean?
CCRN is critical care registered nurse.
Okay, is PHR in pre-hospital?
It's pre-hospital. That's a PA certification. Yep.
Okay, and CF is probably certified flight.
Certified flight registered nurse.
I knew that one. Okay, and she's currently enrolled in a master's program studying nursing informatics. So thank you so much for joining us, Erin. As we've kind of been doing this project, I absolutely love having guests on the show from diverse backgrounds. And something Ken and I have been talking about is we don't know much about flight physiology at all. Neither of us are flight medics. I've never been on a helicopter. I've seen some, but Ken, have you ever flown on a helicopter?
No, it's funny. I actually I had one ride along or fly along set up one day. And I went, and it was with MSP Aviation. No calls in a 12-hour shift, and that.
That always happens when we have ride-alongs.
Yeah,
and the tones drop as soon as you leave.
We didn't go anywhere.
Yeah, I think I'm too fat, quite frankly. Like the one guy was like, "Yeah, man, you're just too big. The pilots aren't going to take you." Mind you, they're like flying tanks in the air. Like I feel like they could take like 10 people, but it's fine. I'm not upset. It's fine.
Weight limit's usually 220.
Yeah. Oh, fair enough. All right. So we'll be, but I feel like, never mind. I won't go on that subject, but I feel like a lot of those trooper medics are not 220. Like, come on. Have you seen some?
That's specific to stat. I feel like they probably have some different rules.
Yeah, because I feel like your helicopters are a lot smaller than like.
They are. They're much smaller than MSP's helicopters.
Yeah, because, well, never mind. I'm not going to speak to that because I don't know anything about it. But so on to flight physiology. So I think I talked to you about this before we started recording, or definitely before when I contacted you. We try to take a approach that is based in applied physiology when we talk about any subject on the show, right? So I think something like the changes that occur in flight are pretty crucial because you're changing how baseline human physiology works, which definitely has to be taken into consideration when we're transporting patients that have probably a pretty critical disease process going on that's having them that meets the indications for flight, right? Like generally these
Correct.
Are more critical patients. So
typically they're your time sensitive, like critical patients that need some type of intervention, or they're just too darn sick to be where they're at.
Yeah.
Sorry.
No, you're good, Ken. Go ahead.
Just for clarification, when we're talking about these kind of physiological changes, is that really impacting everything from ventilation through medication metabolism and basically everything? Are we talking about a real systemic effect?
So what you're mostly seeing with flight physiology impacts is you're seeing an impact on oxygen delivery, and you're seeing an impact on like your body cavities that have air in them, like your sinuses. Your gut is full of air because you're seeing pressure changes. So really where you're seeing it is your GI tract, your lungs, your skull. It's a big brain box, your middle ear, your sinuses, and even in your teeth. Those are kind of like the big areas that are going to be impacted by flight.
So some pretty big stuff.
Yeah, I mean, your lungs and your brain are pretty important. So yeah, everyone likes you to breathe. So yeah, it can definitely have some impacts on it. Obviously, the higher you go, the bigger the impacts. But it's just something that you always have to be thinking about. We typically fly about 2,000 to 3,000 feet here on the East Coast, and you will see some of the impacts of like hypoxia or things like eardrum rupture and things like that. And like the higher you go, the worse it can get. So if you would do, say, fixed wing transport where you're in a pressurized cabin, if you lose that pressure, you see greater impacts. So the higher you go, the greater the impact.
Okay. So when you all, so what are some inclusion criteria that your program follows when electing to fly versus electing to transport by ground?
So everything goes through HopCom for the Hopkins, at least the Hopkins transports, and then there's STATCOM. There's not a lot of consideration regarding flight physiology when deciding ground versus air, just because we're rotor wing, we're only going so high. So we really aren't limiting patients to be able to fly based on what's going on with them, based on like what the impact of flight's going to be. Typically it's, your time sensitive critical illness. The faster they get there, the better. Because we'll fly, like say someone's got a pneumothorax, they absolutely can go in the aircraft at 2,000 to 3,000 feet. It's not going to be a huge impact. It's something you need to consider, but and you need to make sure that it's, you've been decompressed, you've got a chest tube, things like that. They might require more oxygen during transport than they were on the ground. It's just kind of things you need to think about. If they're hooked up to suction, you want to make sure they stay on suction, because that gas, like in that lung, is going to expand as you go up. It's not going to be as significant as saying going to like 10,000 feet, but you're going to see some changes. It's more of being aware of how it can impact the patient as opposed to limiting that they can't go on the aircraft.
Okay. Are these patients usually like intubated, like from your experience, or is it a vast array of?
Surprisingly, I would say less than 50% of the patients we fly are intubated.
Interesting.
A lot of patients that we're flying are like your strokes that need to get the neuro IR and things like that. But we definitely do see intubated patients. We'll see patients that are on, just nasal cannula, patients that are on high flow oxygen, things like that. But I would say ballpark, less than 50% of our patients are intubated.
Ken, did you have some?
No, I was just thinking that. I was surprised that less than 50% are intubated. Yeah. Because usually when you think about somebody who's so critical, they need to be, flown out. Are you primarily interfacility? Is that? Yeah.
So the way Maryland is set up is MSP basically does all of the scene flights, and then there's that hierarchy. Like if there's some type of mass casualty event or some type of catastrophic failure of something, that we're somewhere on that list where if MSP couldn't do it, we would be called. It gets different because we're partnered with Stat Medevac. We could, in theory, go into PA and do scene runs up there, but we won't. Our base in Baltimore, 1 or 2 scene runs a year. So we're basically an inter-facility transport system.
Okay.
So is your crew generally like a paramedic, a nurse, and a pilot?
Yeah, we are typically a medic, a nurse, and a pilot. Sometimes we'll run nurse. Okay. The way protocols are set up, like MSP will do a medic, but the way that other things work, we're always nurse medic or nurse.
Yeah, and especially once you get into the like the critical care transport side of the Maryland State Protocol, right? Like you pretty much need
you need a nurse for a lot of the stuff.
And even the specialty care paramedic isn't, not specialty care. It's like SCT, right? Like special critical transport or something. I don't know what it stands for. But even they can't do that much compared to like the nursing scope. So that was going to lead into my next question. So do the pumps that you guys use have to be like, do you have to adjust any like settings on them because of altitude, or is that
No,
okay.
we actually use the exact same pumps that the ground trucks use.
Okay.
So I could, if say one of our pumps broke and we had no other options, I could in theory go steal one off of the truck and it would work just fine.
Okay.
Oh, cool.
That is pretty cool because that's always something that I wondered, like, and maybe at the definitely yeah, like you said, at the altitudes, but like fluid expansion and stuff with altitude, so that's good to know.
Yeah.
What else do I got? I have a few notes here. Ken, you got anything?
Off the top of my head, the one thing I'm wondering right now is, you mentioned you're usually flying at 2 to 3,000 feet. Is that correct?
That's correct.
Okay, so in areas where maybe there's a higher elevation where they may be flying higher, do they need more specialized equipment compared to what you're carrying here?
No, so I have a good friend who flies out west, and she flies at much higher altitudes, and she also will do some rotor wing transports because especially out there, everything's so spread out a lot of the times. I mean, she'll do the fixed wing transports because sometimes it's just too far to do rotor wing, but her equipment is basically the same equipment as mine.
Okay.
Gotcha.
Have you ever worked in fixed wing transport, just out of curiosity?
I have not. That's
Okay.
yeah, that's not so. I've gone and picked up patients from the airport that have been transported by commercial airlines, and the one that I remember most is a young gentleman who had been intubated, sedated, on drips, on vent, all that kind of stuff, and the paramedic on that flight was using just standard equipment.
Okay. Could you give any insight into what kind of conditions or situations might cause someone to need an actual fixed wing transport, like they're going to fly across country or across multiple countries to get specialized care?
Yeah, so at Hopkins, because they're international, they will have a lot of patients from the Middle East that will come here for treatment. So it was actually a really cool thing to see how there's a lot of commercial airlines, especially Qatar, where they can basically turn the back of the aircraft into an ICU. And then you get all the way to the back of the aircraft and they can set up basically like a mini little ICU for this patient.
No, that's fascinating.
And it's nice because over in the Middle East, they have these wonderful pieces of equipment to help like get that patient onto the aircraft because it's challenging. Really small aisleways, getting a critically ill patient all the way to the back of the aircraft. And then when they come to America, we put them on a backboard and stick them on a drink cart and push them down the hallway. That was the last call I did on orientation at Hopkins, and it'll stick in my mind forever.
I'm sure. That's wild.
That general field of like fixed wing transport has always fascinated me, especially when like you go into like the military transports, right? Like so going, especially at the height of the Afghanistan war and the war in Iraq, where troops were being transported from those countries to Germany, and from my understanding, a lot of the ECMO volume was gained from that, from over there. So one of the docs that we're hopefully going to have on the show, he's ex-military. Well, I think he's in the reserves now, but he's pretty high up at shock trauma now, and I think he's the medical director for their lung resus unit. And that's always fascinating to me, like what, if any, right, what changes have to occur in that moment. So, and I know we're kind of going away from flight physiology, but like say a patient goes into arrest in the air, that's pretty tight spaces that you all are dealing with, right?
It's you're not going to get the best CPR you've ever gotten. It is very tight. Obviously, we do the best that we can. We will unbuckle and come out and let the pilot know so that we're aware that we're out of our seat. But what we really, if you anticipate the patient going into arrest, or you're transporting a patient that's been in arrest, like I've transported out of Howard County not that long ago, you could absolutely throw a Lucas on them and load them in the aircraft with Lucas on.
Interesting.
Really well, especially. So the two aircraft within Stat Medevac, you have an EC-135 and an EC-145, and you can actually load the patient with the Lucas device on without popping off that top part, and they'll fit the clearance and you can just load them right in. But it's very nice to have that Lucas, especially in the back of an aircraft.
So yeah, I mean, I'm sure from number one, from a safety standpoint, but also from a efficiency of compressions in the air, right?
Right, because there's two people back there. That's all we've got, and you can only do so much with two people. So having that Lucas is I remember years ago when I first started hearing about the Lucas, I'm like, oh, there's no way a machine can do CPR like a human can do it. It's such a horrible idea. Now I support it 100% after I've seen it work. Like this woman, she was going to Hopkins for VA ECMO. She'd had a STEMI. She was going in and out of VFib, VTAC. She walked out.
Yeah.
She walked out of the hospital.
I've heard of, compressions that are providing such great cerebral perfusion that we're getting patients that are regaining some sort of consciousness, right?
And she was awake while she was getting compressions. It's the first patient I've ever seen that was awake while getting compressions, and it blew my mind.
I actually have a question related both to this subject and flight physiology. So you're talking about CPR, you're talking about mechanical CPR in the aircraft. Are there changes that occur that impact coronary perfusion pressure while you're doing CPR in the air? I don't know if that happens at 2,000 or 3,000 feet, but theoretically, could that be an issue?
Honestly, I don't think it would be, just because like we are flying at such low altitudes, and I think so there's this so from 0 to 10,000 feet is called the physiologic zone. And that's kind of where your body typically maintains functioning in a way for you to maintain and complete tasks without a big impact. So honestly, I don't think it would. I can't 100% say that, but just based on how the body functions, I don't think altitude would impact cerebral or coronary perfusion pressures.
Okay.
So, and for the audience, I just want to describe, I guess my understanding of, the changes that occur. So obviously, we use oxygen to, as the final electron acceptor in the whole, cellular respiration thing that we all love to talk about, and then we expire CO2. So as we increase in altitude, the general, there's volume expansion, correct? And that's
correct.
The primary concern.
Yeah.
And similarly, so, and we were talking about this a little earlier, when we have patients that dive, right, at an extended, then they can have, nitrogen toxicity, right, secondary to...
Yeah, like the bends.
Yeah, like the bends.
Yeah.
And I don't know the physiology behind that well at all. But we kind of talked a little bit about, I think there's a misconception, or maybe it's not a misconception, but you generally shouldn't fly patients at like the 2,000 to 3,000 foot range that have had a diving accident. I know that you said you didn't know too much about it, but I just want to see. Yeah.
As far as like someone who's having like a decompression sickness from diving and coming up too fast, I don't know if flight would be contraindicated for that kind of patient. I could guarantee like a fixed wing where you could pressurize the cabin would be appropriate, depending on how far they have to go to get to a hyperbaric chamber. But I do know that, other types of patients that need dove, like patients with carbon monoxide poisoning, they will get flown for hyperbarics.
Yeah, because I feel like at that point, if you need that resource, it's also time sensitive, right? So which is one of the indications for, flight, from my understanding, my very crude understanding of flight. Of flight. So no, I mean it's really interesting. I mean, so and I know you don't do a lot of 911 runs, but even for our inter-facility folks that listen in, or in pre-hospital folks, what are some tidbits or things that they may not know that you take into consideration when you walk up to that patient, right? That you just landed your aircraft, you're going to that community hospital. Like what are some things that you take into consideration, whether they're assessment findings or anything really?
So, in relating specifically to flight physiology, I like to know if they're a smoker, because almost always those patients will develop some degree of hypoxia in flight and will require oxygen, not significant amounts, but knowing if someone's a smoker, then I'm going to know if I'm going to need my nasal cannula ready. If they have any type of like lung history that maybe not have brought them in the first place, like say they've had a stroke, but they've also got like raging COPD. It's good information to have. It may not be impacting them right now, but once I take them a few thousand feet in the air, it could impact them. Just like in the back of the ambulance, if they are the type of person that gets motion sickness, like I want to know that before we get started, so that way I can pre-medicate, because you can't catch up. Yeah, like you absolutely can intubate someone in the back of an aircraft, but it's not a good day. Another thing to take in consideration, especially if you're flying in daylight hours, if you have a patient that you're either flying for seizures or if they have a history of seizures, it's really good information to have, because there's this thing that it's called flicker vertigo. So it's the rotation of the blades with the sun coming through can actually trigger seizures.
Oh.
So if you're transporting someone, any type of patient that's at risk for a seizure, like a subarachnoid, if someone's in status, like you're going to want to take a washcloth or something and cover their eyes, because it doesn't happen often, but it can happen that the light coming through the rotor blades will trigger seizure activity in some cases.
That is something I would not have thought of at all.
Yeah, it kind of blew my mind when I learned that.
Yeah.
Like I would never have thought, but it's just one more thing that you take into consideration that you would never take into consideration transporting a patient or doing anything with a patient any other time.
Yeah. Yeah, and I think this goes without saying, but you 100% have access pre-established before you ever lift off the ground, right?
Correct. Yeah. You to leave with a patient without peripheral IV access is a consult to your medical command.
Bad medicine. Yeah.
If you can establish access, absolutely do it. I have flown one patient who did not have access because it was time sensitive and she was a stroke going to neuro IR. But you have the plan in place that if anything happens, I'm drilling her.
Yeah.
But yeah, that I've only done it once. Just because she was so time sensitive, but everyone gets an IV just because you never know what's going to happen.
And just for our listeners that don't know what IR is, it's interventional radiology, correct?
Correct. Yes. And interventional radiology has kind of been a game changer for stroke care, which is a whole nother interesting topic.
Yeah. So we're starting the pilot where, I volunteer with the, with a LAMS greater than I believe 4 or 5. We're going to be diverting to a comprehensive stroke center for the thrombectomy capability, which is it's insane. I forget what we were recording about a few weeks ago, but we looked into the number needed to treat for thrombectomy, and it's like 1 in 2, I think, or something like it's insane.
It's insane. It is absolutely insane. And the fact that you can take these people, have no idea what their last known well is, and they're going to regain some function.
Yeah.
It's pretty amazing.
And
there's been a lot of really good studies.
And these are people that when you see them, they are really sick. That used to be, you were like, this person's probably not going to have a good score coming out of that hospital if they come out. And they're walking out sometimes, right? Or they're going, and it's another, absolutely, as you said, another great topic that we do plan on discussing at some point.
Yeah, neuro IR has been a game changer for stroke care.
So I wanted
to. Really
sorry, go ahead, Ken.
I was just going to say, it's amazing to me that it's such a fantastic tool with such great outcomes, but so few people are aware of it. Even in our area, the greater Baltimore area, where we've got 3-4 hospitals that can do this, people they have no idea.
Mm-hmm.
Yeah.
Now I will say also on the opposite end of things, there are EMS clinicians that feel that all strokes should be going to a comprehensive stroke center. And, they really don't understand the underlying physiology. And I approach, and my big thing is if I see folks saying that, I understand that I don't know enough about the topic to be able to comment on the topic. So I go to look for information. So I went and speak to, my mentors that are, at least the physicians that are making these protocols. And I'm like, hey, why would we not want to take a patient, every stroke patient, to a comprehensive stroke center? He's like, because the thrombectomy that they're doing is only for large vessel occlusions. And if you have a microvessel occlusion, what's going to help with that? A CT scanner and TPA. And
Correct.
if you're diverting from a facility that can provide that intervention, then you're essentially doing harm, right? So, and again, I think that's going to be something that we talk about in another episode. I did have one other flight related question. So we just had one of our good friend of mine, Emmett. He works for I think he works for MedStar's flight program in DC. He just did an article for us. Talking about the use of ultrasound in flight, because obviously, you're not going to be hearing anything with a stethoscope.
Yes.
So what are your thoughts on that? Have you used, ultrasound before in the
We don't have ultrasound in our program, but I have had a chance to play around with it in a couple different settings. When I worked at University of Maryland in the CCRU, one of the attending physicians is an ultrasound guru. So I kind of got to learn a little bit from him and play around with the ultrasound. I think it's an amazing piece of equipment. I know a lot of flight programs do have it. I would love it if our program got it. You can do a lot of really cool stuff with it.
But yeah, I mean, I think that was a pretty Ken. That's pretty much all I had for flight stuff. That questions that that have always been of interest to me. Things that I didn't know about flight, because I don't know anything about flight. But those are the questions. Ken, you got any burning questions you can think of?
Yeah, I was just curious if you could touch on the how fluid volumes change in flight and some of that stuff.
Yeah, so specifically, like gas type fluids is what we're most concerned about. Like liquid fluids, you're not going to see a whole lot of changes, but with your gas fluids, you're going to see a lot of things. So you're going to see a big impact in your GI tract, because you've got tons of gas, and it's a wet gas, so it expands even faster. Your average patient probably going to be fine, but if you have someone with like a small bowel obstruction, or someone that maybe had been getting bagged before they got intubated and kind of blew up their belly a little bit, you're going to want to make sure that you are able to decompress that abdomen, because most significantly, it's just going to cause them a lot of discomfort as those fluids expand. So you're going to want to drop an NG, drop an OG if they don't already have one, and decompress that belly, especially people that are obstructed and don't really have normal GI function. And then also with your sinuses and with your middle ear, you've got air in those cavities. So specifically with your middle ear, you can develop something that they call an ear block. And that's when it's a problem on descent. So once you come up, you're fine. But as you're coming back down and that gas is not able to vent out of that cavity, you can develop severe pain. You can get things like tinnitus, nausea, vertigo, and then you can also wind up popping your eardrum because you're not able to vent that. So that's where you'll see like tympanic rupture. I've never seen that happen to a patient, but I have had that happen to a colleague where she did have her eardrum rupture in flight.
Oh, and that's an interesting thing to get to as well, and I didn't think about this until now. What are some other long-term side effects that you feel, after, flying, especially folks that do it for a career, like anything like that you can think of?
So you can have impacts on your hearing, obviously, because it's so loud. Even with, we all have helmets, we all have hearing protection, but just that constant exposure to sound and vibration. There's a lot of vibration. You can have long-term impacts on your hearing. Most of it is a short-term impact. It causes like an increased level of fatigue. Like I'm sure you guys feel it in the back of the ambulance too, when you're bouncing around all day, all the vibration, and now you're adding in altitude changes and pressure changes, all the significant temperature changes. You're going from an air-conditioned hospital to a hot aircraft. It adds up to like a lot of fatigue.
I'm just out of shape.
It's mostly just issues with hearing long-term.
Gotcha. Aaron, did you have any other last things that, for the average Alert Medic 1 listener, anything you would want to, any tidbits, I guess?
I think, like I said, flight physiology is, it's not super complex once you know what it is. It's all, and if you're really interested into it, you can deep dive into some of the gas laws and physics, which is basically what dictates how all of this stuff happens. But
Boyle's law.
It's very dry. It's not very exciting. But what it does is it explains why everything happens. So there's a lot of science and physics behind why all these things are happening.
I remember that 1 atmosphere is 760 torr. Is that right?
And that is absolutely correct.
Oh,
yes.
Look at that. College education. Helping random facts. Hey, listen, Aaron, thank you so much for joining us. So we're also going to be doing an ECMO episode with Aaron, but I think we're going to be recording that at another, well, maybe not another time, but another episode. Thank you so much for joining us. As I'm sure you all heard, we are trying out a recording via Google, so thank you for being patient with us, as our recording quality may not be up to par as it has been. But as always, and Ken always does this better than me. Ken, you want to give them our spiel?
Sure. So thank you for listening, everybody. Please check out our website, www.alertmedic1.com. Check us out on Facebook, AlertMedic1, Twitter, alert_medic1. And most importantly, please subscribe to us on your podcast app of choice. Leave us a rating and a review. Let us know what you think. If you have any suggestions for topics, we'd love to hear them. And we'll see you next time on Alert Medic 1.
Thank you very much.
You've been listening to the Alert Medic 1 podcast, the premier emergency medical services podcast with your hosts Mustafa Siddiq and Ken Sanner.